Hello, and welcome to our program entitled Combine and Conquer, Minimizing the Impact of Toxicity Associated with Novel Immunotherapy Angiogenesis Inhibitor Combinations. This program is supported by an educational grant from Eisai Inc. and Merck Sharp Dohme LLC. Before we start, there's a few housekeeping items. If you could please take a moment to answer the pre-polls in the tweets below and let us know who you are. This is a CME certified program. The tweets below also include details regarding how to obtain your credit. And of course, be sure to follow our handles for additional CME programs on Twitter. I'm Mike Pishvaian. I'm an associate professor of gastrointestinal oncology at Johns Hopkins University. I'm also the founder of Tumor Board Tuesday, and I welcome you to this talk. I'm joined today by my colleagues, Drs. Yarchoan and Baretti.
Good to be here. I'm an associate professor of medical oncology at Hopkins, focused on hepatobiliary tumors.
Hello, everyone. It's really a pleasure to be here today. My name is Marina Baretti. I'm an assistant professor of gastrointestinal oncology at Johns Hopkins University.
Our disclosures are shown on your screen. And upon completion of this educational activity, participants should be able to express awareness of adverse events associated with anti-angiogenic therapy and how they differ from immune-mediated adverse events, differentiate the etiology and presentation of overlapping toxicities with anti-angiogenesis therapy with IO combination therapy, and select optimal strategies to prevent and manage common adverse events experienced by patients treated with anti-angiogenesis plus IO combination therapy. Dr. Yarchoan, do you want to get us started off?
It's really an exciting time to be treating hepatocellular carcinoma. When I started treating this cancer, we really had one approved therapy, sorafenib, which prolongs life by a median of about 2 to 3 months and has substantial toxicities. And really over the past 5 years, there's been really a remarkable amount of progress with multiple new therapies in both the second line and also the first line, with more therapies expected soon. And really, I would say the most transformational thing has been the incorporation of immune checkpoint inhibitors in the treatment of this disease. I'd like to start us off with a case here. So we have a 60-year-old man with a history of NASH who presents to the emergency room with some abdominal pain and back pain, undergoes a CT scan that unfortunately shows an 8-centimeter mass in the liver, along with both lung and bone metastasis. This patient underwent a biopsy that confirmed HCC, although technically that may not have been necessary. You can see on the right, the patient has well-preserved liver function, is Child-Pugh A, the AFP is normal. What would be your preferred treatment option for this patient?
So in this setting, I would prioritize a treatment with bevacizumab plus atezolizumab based on the IMbrave 150, given that the patient has had an EGD and no risk of bleeding at that type of investigation.
Mike, do you agree?
Yeah, I think that makes sense for this patient. There are certainly other considerations that are coming down the pipeline, but that is certainly the current established regimen.
You know, obviously, I agree with everyone. This is a pretty straightforward case, and really, guidelines right now list atezo plus bev as the preferred option for these patients. You really need a reason not to use atezo bev in a patient like this. Why atezo-bev? Well, atezo-bev is the only approved therapy at the time of this recording that's shown improved overall survival versus our old standard of care sorafenib. As was mentioned in the IMbrave 150 study, the median survival was 19.2 months for the atezo-bev versus 13 months for sorafenib. And this was, a truly positive study. It didn't only prolong overall survival, but also PFS, objective response rate, and toxicities. You can see here, sorafenib and other TKIs, one of the challenges we have are TKI type side effects like diarrhea and hand-foot syndrome, and you don't tend to see those things. I think the one side effect that is worth spending a little time talking about here are bleeding events. So numerically, there was more bleeding with bevacizumab and atezolizumab over sorafenib, and that's despite attempts to limit the amount of bleeding by requiring everybody to undergo an endoscopy before treatment with bev-atezo. Marina or Mike, any thoughts?
I perfectly agree with you, and I think we can, just run some scenarios just to dive into more details. Let's assume that at baseline, the patient blood pressure was within normal limits, less than 130/80. And then 3 weeks after starting treatment, the blood pressure is slightly elevated, 150/90. Probably one of the most common toxicity that we can see with different type of anti-angiogenic, including bevacizumab, which is the risk of hypertension. I just want to pick your brain about how you monitor the blood pressure at baseline, how you select or evaluate the patients, and then how you monitor and maybe treat blood pressure.
I think it's important to remember that without treatment, these patients have a median survival of 6 months or less. So, we do need to think about the underlying risk of not treating. And I can count on one hand the number of times that I've actually withheld therapy because of hypertension. And I probably wouldn't in a patient with a blood pressure of 150/90. This probably wouldn't faze me. I would add an antihypertensive agent here and keep going.
Do you have a hypertensive class of choice, Mark?
ACEs or ARBs, along with, calcium channel blockers like amlodipine are things I rely on. Marina?
I agree with you. Blood pressure in those levels usually does not trigger withholding treatment, but I just start anti-hypertensive medication. I tend to start with calcium channel blocker and then add the ACE inhibitor and angiotensin receptor inhibitor as a second drug if the blood pressure is not under control. The second scenario is what you already mentioned, which I think is a key point for this combination of treatment, which is the majority of our patients have some sort of underlying cirrhosis, which can be complicated with portal hypertension, which of course increase the risk for this patient to have esophageal varices that of course can bleed. As you mentioned in the IMbrave study, bleeding was probably less than 10%, 6% or so, but those were patients that all had EGD within 6 months of treatment, and patients with high risk of varices were treated before entering the trial. So I think the question is, how much do you recapitulate what was done in the clinical trial in your clinical practice as well?
I can tell you from adopting some of these patients from Mark that he tries to stick very much to the study. And I think it's the safer thing to do. It does add increased burden on the patient and, quite frankly, the healthcare system to get endoscopies on these patients if they haven't had them recently. But at the same time, because of the risk of complications, it can be dramatic. It's definitely good to know what's going on with these patients endoscopically.
I think one area that's still contentious is whether it's okay to just start carvedilol or a beta blocker as appropriate therapy for varices, and to do that and then start therapy. And I think there are limited data, and I wish we had more data to do this, but I certainly have patients who radiographically don't have varices who seem to be pretty low risk and where there's some sort of terrible delay in getting an endoscopy. And I think in cases like that, it's not unreasonable to treat, but we don't have data.
Another strategy for which there is absolutely no data, but it's coming more from clinical practice, is if you think that you can get the endoscopy, let's say within 3-4 weeks, but you don't want to wait that time. I have sometimes started with atezolizumab single agent and adding bevacizumab only after the endoscopy. But again, this does not come associated with any data that it's okay to do and the efficacy will be the same. I think so, and I assume so, but it would be nice to look retrospectively.
Marina, in the IMbrave study, as I recall, about a quarter of the patients had hepatitis B, and they're not necessarily cirrhotic patients. Do you do endoscopies on patients who are not cirrhotic?
I tend to do in every patient, but as Mark mentioned, if they're not cirrhotic, there is no radiographic evidence of portal hypertension, I feel more comfortable to start even without an EGD. And then I think another question that comes with the use of bevacizumab, for which I'm not sure that we even know exactly the mechanism, and probably there are even less data on how to manage the treatment, of anti-angiogenic when we encounter proteinuria. In clinic, we do obtain an urine analysis at every cycle, and usually if the proteinuria and the dipstick reading is 1+, I just continue the treatment with bevacizumab, and then if it's 2+, that's where I get a little more nervous, and I obtain a 24-hour urine protein just to make sure that the proteinuria is not in the nephrotic syndrome range.
Yeah, I mean, just anecdotally, I've seen this much more commonly in my African American patients, and so again, not a lot of data, but I check urine dipstick monthly for African American patients, just because anecdotally that seems to be the population where this is the most likely to occur. In other patients, I probably check it every couple of months. It's hard to know what to do with this. Again, we're balancing the chance of ending up on dialysis versus the chance of losing control of a very aggressive malignancy. So it's hard to just say, blanket statement about what to do. But I think when patients truly have 3+ proteinuria, we pause the bevacizumab and would just continue the atezo monotherapy. Of course, I think it's worth noting that patients can also get immune-related adverse events that can mimic proteinuria from Bev. So, often you need to get a biopsy. I think it's super helpful to have nephrology see these patients when you really are dealing with nephrotic range proteinuria.
One of the things I was going to say is that we definitely learn from our experience in colon cancer and bevacizumab, where patients that are on bevacizumab often for many, many months. And this is something that tends to happen many months down the road, that they're getting the proteinuria. And I think seeing it now being an issue in HCC is as a result of better therapies that are allowing these patients to stay on longer. But in the colon cancer population, just even stopping the bevacizumab for a while can sometimes allow the proteinuria to recover, and you can re-challenge those patients as long as they didn't get into real trouble.
Another, toxicity that we encounter very often, especially in patients with HCC, which can be sometimes difficult to interpret, is the elevation of the liver enzyme, both AST and ALT, with or without elevation of bilirubin. So this is the same patient. About a month after starting treatment, she has an elevation of AST more than 7 times from her baseline. ALT are also mildly elevated, and the bilirubin is maybe 1.5 from the upper normal limit. So this, of course, opens the question or raises the concern about an immune-related toxicity from the immunotherapy. But I guess in the differential, in my mind, will be also maybe progression of her disease if the patient started, with liver involvement. And I guess really opens the dilemma for people like us who treat hepatocellular carcinoma on how to interpret those numbers in patients who have already at baseline liver involvement, and most of the time they have also baseline increase of the liver function test as well.
Yeah, I mean, I think these cases are really challenging. Obviously, repeating imaging can be helpful. If you see this sort of elevation in a patient with a really minimal disease burden, certainly makes you more suspicious for an immune-related adverse event. And I think typically what we would see would be more AST, ALT elevation, less alk phos, less bilirubin. That's the more classic pattern that I've seen. And I think these patients, usually this is reversible with some steroids. Sometimes you need a second agent, like Cellcept or something like that. And in my experience, this can take a long time to resolve. I don't know if that's your experience as well.
Yeah, I think that one of the benefits of being a little bit older than you guys, just a little bit, is having seen the development of these checkpoint inhibitors in their infancy, and having really sort of unfortunately witnessed some of these patients have very life-threatening autoimmune reactions. And the one lesson that I learned and is ingrained in my brain is the idea to jump on any potential autoimmune reaction very, very quickly. Because now, as a result, in 2022, we do reverse these autoimmune reactions so often and so quickly and so well, as long as we're thinking about them very, very proactively. And the other thing that's nice to have learned in the last 10 years is that these immune checkpoint inhibitors, they are not necessarily going to be suppressed by a course of steroids the way that we were worried that they were going to be 10 years ago. And so if you jump the gun and start these patients on prednisone, and it turns out that they don't have an autoimmune reaction, you can always scale back and then resume the therapy if it's appropriate to do so. So I think that always erring towards the side on jumping on potential autoimmune reactions is the better way to go.
All right, so next case, we have a 68-year-old woman with chronic hepatitis B. She presents with nausea, abdominal discomfort, undergoes a CT scan that unfortunately shows multifocal lesions in the liver and a lung lesion as well. This patient has reasonably well-preserved liver function, although her platelets are pretty low at 68 and her AFP is elevated. She's still Child-Pugh A. This patient is at particularly high risk of bleeding. I guess it's not included in this prompt, but let's say that she has a history of a variceal bleed in the last 6 months. How would you approach a patient like this?
So these are very challenging cases for all the discussion that we had so far. In a patient with very large infiltrative mass, HCC can rupture, can bleed themselves, especially if there has been already a history of bleeding from variceal bleeding, meaning that they have probably a bad portal hypertension as testified by the low platelet. Those are patients for which I'm not very enthusiastic about the use of bevacizumab and atezolizumab, and I try to avoid. So in a kind of scenario where all medications are available, regardless of the actual FDA approval, these I think are the patients that I will evaluate, and I will candidate potentially to an immunotherapy only based approach. Of course, we have now the possibility to use a single agent that can be effective, but they are effective probably in a minority of patients, maybe 15% or so. And more recent, we have data from the Himalayan, which if you have a combination of IO agent, anti-PD-1 plus anti-CTLA-4, you can actually achieve a much better clinical outcome from all the major outcome in terms of overall survival, progression-free survival, response rate. So if available, that would be my choice in this situation.
You're touching upon, I think, the durva-tremi data from the Himalaya study. Again, at the time of this taping, this regimen is not yet approved, but I think it's helpful to sort of talk about it because it's likely to be an option in the near future. So just for people who aren't aware of this, this was a phase 3 study combining durvalumab and tremelimumab being an anti-CTLA-4 agent. And based on the phase 1 study, there were a couple of different dosing strategies that were explored, but the regimen that moved forward in the phase 3 study was a single sort of priming dose of tremelimumab, which is a pretty high dose given once, along with durvalumab. And we'll just go over the data here. So as you can see, this is a second regimen that demonstrated improved overall survival versus sorafenib. It's likely to become an option for patients in the first line setting. We don't like to do these sort of cross-trial comparisons because again, these are two different regimens done in different studies. But, I'll say looking across the data, the response rate appears a little bit lower. The PFS was not prolonged, whereas it was with bevatezo. The thing that excites me about this data is you can see really for the first time 3-year survival. This is not something we've talked about with other HCC regimens before. And you can see there appears to be some flattening of the curve. About a third of patients are alive at 3 years, and the curve seems to flatten. We don't have 3-year data for bevatezo. It's possible we'll see the same thing, but it does suggest that immune checkpoint inhibitors, when patients respond, they can be very durable. In terms of adverse events, I think the key thing to know is that this regimen was associated with a high proportion of patients experiencing immune-related adverse events. Overall, the grade 3 or grade 4 adverse events were approximately double what was seen with durvalumab monotherapy. So clearly adding the tremelimumab adds a little bit in terms of efficacy, but with considerably more immune-related adverse events. So, I think for a patient like what we described in this thread here, a patient who, may have had a history of bleeding, has low platelets, where bev-atezo is contraindicated because of the bevacizumab component, I think an immunotherapy alone strategy like durvalumab would be very reasonable, and we certainly hope that this will become an option for our patients in the near future. I'll turn it over to you, Marina.
Thank you. So this is a patient, 77 years old woman with history of heavy alcohol use and cirrhosis related to that, which unfortunately presents with abdominal pain and fatigue, and the full workup eventually showed hepatic mass up to 4.5 centimeters, consistent with hepatocellular carcinoma, but also distant metastasis in the lung. Her child-pug is still very well preserved, which is class A, but her past medical history is significant for autoimmune disease for which she required steroids. She's still on immunosuppressive medications. So I'm really curious to see, what would you recommend in this case?
This is a patient who is not going to be able to get an immune checkpoint inhibitor. And so TKI like lenvatinib or sorafenib would be ideal. We know that lenvatinib was non-inferior to the sorafenib. And the lenvatinib definitely did show benefit to this patient population. We don't really know the benefit of giving them a checkpoint inhibitor in addition to the TKIs, but obviously this patient wouldn't be able to get a checkpoint inhibitor anyway.
Yeah, no, I agree with everything. I think a patient where immune checkpoint inhibitors are truly contraindicated, I think treatment with a TKI is very appropriate. And, again, we have plenty of data from TKIs before we had bevacizumab and atezolizumab. We had the recent LEAP-002 study, which looked at lenvatinib as a single agent or in combination with the pembrolizumab. And, what I think surprised me was just how well lenvatinib performed in a contemporary population where patients had a median survival of 19 months going on frontline lenvatinib. So, I think in the modern era, first-line TKI and in well-selected patients, patients can actually still do very well, and I think is a very appropriate choice here.
Yeah, I agree with you. And even if we look at the initial REFLECT study comparing lenvatinib to sorafenib, it's true that they were not inferior in terms of overall survival, but for other endpoints, which are still very important, lenvatinib was clearly superior to sorafenib with almost double in PFS and almost 3 times higher response rate as compared to sorafenib. The other point that we need to make is about the toxicity. Both lenvatinib and sorafenib are TKI that target different receptors, and overall, probably some of the toxicity overlap. But I think you can argue that the risk of what we call the hand-foot syndrome and the palmoplantar erythema syndrome tend to be much higher and more serious with sorafenib, leading to dose reduction and discontinuation. And we probably see, we have seen less in the clinical trial, but I think also in clinical practice with lenvatinib. On the other hand, GI toxicity tend to be common for both agents. So I'm also curious to know what is your management of this toxicity. In my practice, I tend to choose lenvatinib over sorafenib for what I just mentioned. And even though the recommended dose is 12 milligram, it's not unusual if a patient is particularly frail that I start with a 8 milligram, or that I have a very low threshold for a dose reduction from the 12 milligram to 8 milligram. And I think it's very remarkable how even this small change can actually result in a much better tolerability for patients. So again, close monitoring of side effect, getting this patient in clinic early on during treatment to see how they are tolerating can have a huge impact on the ability to keep patients on treatment without significant delay or holding therapy.
Marina, if you see a patient with bad hand-foot syndrome, do you take a pause on the lenvatinib? And if you do, for how long do you wait?
It really depends. We tend to be very aggressive in, in managing the end of foot syndrome, but we tend to hold and then we monitor patient. I ask the patient to upload picture. I look at the picture, and once I see an improvement to at least a grade 2 or less, I tend to restart. If it was on 12 milligram, I might restart at the 8 milligram. If it was already an 8 milligram, it really depends for how severe it was and for how long it takes to resolve. We probably have still some open questions about what is the efficacy overall of combining TKI with immunotherapy. And I'm saying question because even though we have now 3 trials, the results have been conflicting, and I think that, as I mentioned, they leads to more questions than answered in my mind. The very first one was Cosmic 312, presented at ESMO last year. In this case, was a combination of cabozantinib plus atezolizumab, and the control arm was sorafenib. The trial had a dual primary endpoint of overall survival and progression-free survival. And while it was positive for a progression-free survival, it did not show a significant improvement in terms of overall survival. But you can see here how sorafenib, the control arm, outperformed our expected data. The most recent study, which have been presented at ESMO a month ago, were the LEAP-002 trial, combining lenvatinib plus pembrolizumab, and in this case, the control arm was lenvatinib. And as Mark mentioned, lenvatinib outperformed the historical data, and the end result was that this trial was not positive. And then finally, we have also a trial combining rivoceranib plus camrelizumab. This trial had sorafenib as control arm, and this trial was actually positive. But I do want to mention how this trial was mainly enrolling Asian population, with a majority of patients having hepatitis B-related hepatocellular carcinoma. So there are some questions about the reproducibility of this data in a Western population, questions about the role of viral versus non-viral hepatitis in impacting the efficacy of IO. And also from that trial, what I think it's the take-home message is that the toxicity of these combinations can be real. In that specific trial, grade 3 and 4 treatment-related toxicity were seen in more than 80% of the patients enrolled, which of course raise questions about the applicability of this regimen in the day-to-day practice. And I really would like to hear your thoughts about how do you think about this combination, especially from a toxicity perspective, as some toxicity from IO and TKI can overlap.
I mean, I think these studies were, all of them were surprising for me, to be candid. I think we were certainly hopeful that we would have TKI-IO combinations because in many ways, we think that TKIs have considerable efficacy as single agent. Checkpoint inhibitors have single agent activity. You combine them, even if they're just additive, you'd expect that these would be very active combinations with perhaps a little less of a bleeding risk from bevacizumab, shorter half-life, allowing you to combine well with local regional therapies or other sort of local regional approaches. So, I think all of us were hopeful about these studies. And now we're left with really a lot of questions. And I agree with you, starting with the camrelizumab combination that you mentioned, which is the only TKI-IO combo that was positive. As you mentioned, only 20% of these patients were outside of Asia. And this is clearly an active combination, but the toxicity data is concerning. And in particular, we know that our hepatitis B patients have fewer comorbidities, tend to be younger, and tend to tolerate more intensive therapy better than some of our other patients. So I don't know how applicable this will be to the population that at least I see in my clinic. The other thing is that neither of these drugs are approved in the US as single agents. There was no TKI control arm of the study besides the sorafenib control. So I don't know whether this will be approved in the US. I think it remains to be seen. And if it is approved, I would be hopeful that there'd be more data generated before I would use this widely in my clinic. I think the cabo tezo and lenva pembro data, these are both either semi-negative or completely negative studies. And the question is, now that we have such outstanding second-line therapy and the ability to cross over to IO therapy in second line, is it going to be harder to show a benefit in first line? And we may be seeing some of that, particularly in an era where systemic therapy has moved earlier with this sort of stage migration that happens. So that may be part of what happened here, is that patients crossed over to effective therapy from the sorafenib arm or the lenvatinib arm with such long survival in the control group. That being said, we don't look at this data and say, wow, there's great synergy between TKIs and IOs. The hazard ratios are, if anything, worse than we saw for IO versus placebo in second line. So it almost points to some antagonism between TKIs and IO based on this data.
I totally agree. And the last thing that I want to add, which is not just applicable to this combination, but it really applies to everything that we have mentioned. All the data and all the trials that led to the approval of drugs, or that will lead to the approval of drugs, have excluded the patient with Child-Pugh B, which still remains a large proportion of patients that we see in our daily clinical practice. And so far, we have mostly data for single agent IO, and also for some of the TKI. Of course, sorafenib is the agent for which we have most experience, but also for cabozantinib as well. But of course, that's a population a little more frail, in which the risk of toxicity and more severe toxicity is higher. And I think we should do a little more efforts in including those patients even in the trial, because that will give clinician a better way to evaluate what is the impact of, and you might even choose one regimen over other just based on that.
Well, that was really fantastic. And I think what you all have highlighted is that the treatment of HCC has become very complicated, but to the benefit of these patients, we really have seen a significant improvement in outcomes, survival, of course, being the main endpoint. We also know that we have to contend with more side effects and managing and tweaking the therapies to allow patients to tolerate treatment well enough to be able to realize the benefit from a quality of life perspective is also going to be really important. So really, Dr. Yarchoan, Dr. Baretti, thank you so much for your time today. And really, thank you all for joining us today. Please make sure you claim your CME credits by completing the post-test and evaluation form at the link on the screen. Please be sure to follow Tumor Board Tuesday and also Bonum CE on Twitter to stay tuned for more CME programs. Thank you all.